show that's telling you what's really, really, really going on. So we have a good conversation tonight, an important conversation. It's a topic that's all too familiar to so many of us. However, it's something that so many folks seem to struggle with, Dr. Kane, and that is talking about diabetes. Isn't that something? It's just so, and you're zipping it up because what does that mean?
Let's look here. It's the right combination of what we need to do to get our community healthy in terms of when we talk about diabetes. I can't forget his partners, so we have to kind of um, bring in those other two issues, but we'll talk about that a little later. But yeah, you're right. Diabetes is such an important topic, especially in our community, and we're blessed enough to have again Miss Turner.
Linda Lockett Brown. Da, 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 da. Hey, Linda. Linda is
How are you?
has been with us on previous shows. She is a registered and licensed dietitian with too many other initials after her name. So I'm just going to leave it at that. How are you doing this evening, Linda?
Doing fine. Glad to be here.
And we are so happy that you are joining us again. And we're also going to have another guest who is having some technical difficulties. She'll be chiming in soon, and that is Dr. Trishella Johnson Foy. So hopefully, our technological guru Tyrone, will get her back on so that we can begin the discussion. And as always, we like to welcome our guests. You know, there's a Dr. Kane. There are a group of people who, no matter what, they're going to chime in with us on Tuesday night. I don't want to say that it's because they don't have anything else to do. I really hope it's because we have some good stuff to talk about, and they want to hear it.
Yeah, and you're right. It's not because they have nothing else to do, because I think all of them got plenty to do since they've lifted the COVID restrictions. They're no longer stuck with us. So when they're coming in now, that's because they choose to do so.
And since you mentioned COVID, Dr. Kane, before we get to, as we wait briefly for Dr. Foy to come back on, let's talk briefly about COVID because, people think that it's gone away. And hey, Dr. Foy.
Hi, can you guys
Oh,
hear
we
me?
can hear her. Yes.
Hey!
All right, perfect.
Welcome, welcome, welcome. We were just going to say briefly, just touch a little bit before we get started and talk about. I've already told them about how fabulous you are, so they were just waiting. Our listeners just waiting for you to get on. And we see someone photobombing you and behind, but we know when you're home that happens, right? So, Dr. Kane, tell us real quickly, why should we care about COVID?
Well, I mean, the usual reasons that we talked about before still exist, and that is because of the harm that COVID can cause. But I think what you were alluded to earlier, and that was that, why should we continue to be concerned about COVID? And those reasons have not changed, and that COVID is still can be a deadly disease, as everybody knows. People still are dying from COVID. People are still getting sick from COVID. People are still getting infected with COVID. While the variant may have changed, and to some degree, you got those different variants that have come along that may be more infectious, maybe not as deadly as previous variants. You still can get sick and die from COVID, and we still, even though we're in somewhat of a lull, as I call it, we can still we may have another surge, which people are looking at right now, and to the point that we're not sure, even though we think that this particular variant is not as deadly, it still can be a surge. And like I said, it's not like no one is dying; it's just less people are dying.
And we don't
So
want
we
one
still need to
person.
be a cognizant that COVID is out there. It
Mhm.
still can be deadly. Wear your mask, but one of the best things you can do is get vaccinated. And I think our guest, Dr. Trishella Johnson, can tune in on that just as even more knowledgeable than I am.
I don't know about that, Doc. But of course, yes, definitely getting vaccinated is going to be the thing that kind of helps us most. If we kind of make sure everybody around us in our community is vaccinated, it protects us all. So that's what you guys can do to really kind of help get back to that new normal that you want to get back to, spending times with your family, going to restaurants, those types of things.
She slipped in new normal, but we'll talk about that later.
Yeah, it is a new normal. So now I'm going to go ahead and switch gears. Dr. Foy, unfortunately, I know this topic all too well with you. Um, and I don't mind giving telling my personal testimony as we go along. But in 2019, it's the first time I ever cried with when Dr. Foy says something to me. She doesn't know that I cried. I don't think I revealed it to her, but I did cry when Dr. Foy told me that I have diabetes. Now, in full disclosure, Dr. Kane told me when he was my primary care doctor, you're going to get diabetes if you keep going the way you're going. But I'm hard headed, as a whole lot of other people. And again, being fully transparent, since I've gone to Linda as my registered dietitian, she told me your numbers are saying such and such. Well, I'm a knucklehead, just like other people. I knew my family history. But Dr. Foy, let's start with you. What is diabetes? And I'll tell my story as we go along. So what is diabetes, Dr. Foy?
So diabetes is a condition in where the body can't process and use sugar the way it's supposed to. So normally sugar, and when we say sugar, we're talking about glucose. And a lot of times people think when we say glucose, we're just talking about those things that are sweet. But sugar, our glucose, comes from things like pasta, potatoes, bread, rice, grits, those things, which are your everyday staples and not just cakes and pies and creams. So our body normally needs these things. It needs it to use it as energy. When the body loses its ability to do that, then people can develop diabetes. And there's more than one type of diabetes. There's two main types of diabetes. Type 1, where the body doesn't make insulin at all. These are usually young people. They usually are very thin and get very sick because their body doesn't make insulin. In type 2 diabetes, which is what most people have, that, and by most, I mean about 95% of people. I try to have patients remember it saying it's type 2 and there's two things going on. Your body doesn't make enough insulin to cover the entire body. And the insulin that it does make, your body is resistant to it. So those two problems lead to your sugar levels being too high or your glucose levels being too high. And then you can't use that sugar as energy the way it's supposed to walk, to talk, to think, to let your muscles do what it's supposed to do. And because of that, it ends up causing complications when the sugar levels stay too high. And those sugar levels being high can affect every part of your body. And so when we think about diabetes and think about somebody having the sugar, that's what diabetes is.
Thank you, Dr. Foy. And you know, as much as I'd like to believe it, I'm not just super sweet, because you know people hear sugar diabetes. They call it sugar diabetes. It doesn't mean that you're just super sweet. But in all seriousness, do most people who get type 1 diabetes or diagnosed with type 1 diabetes, are they mostly children, or can someone who's older also be diagnosed with type 1 diabetes?
So with type 1, not necessarily children, but young people. Okay. Usually if you're going to have someone with type 1 diabetes, they're usually 30s and younger, that time frame. It used to be that we call type 1 diabetes juvenile diabetes. But the reason why we don't really do that anymore is because actually, most young people get diagnosed with type 2 diabetes in our country. And it's because we have this epidemic of childhood obesity that has led to this. And so because of that, the type 1 diabetes is the nomenclature that we use to really identify it. But you usually are going to see mostly young people where something happens where the pancreas gets attacked and it can't function anymore the way it normally would. And that's what happens with type 1.
So
Parents know when their kids are having some type of symptoms. Are there some symptoms? I'm sorry, Dr. Karen, are there some symptoms that they may be having that parents should look out for?
For type 1 diabetes?
Or either?
For either. And now, Dr. Kane, I don't want to answer that before you go ahead and listen to what you're about to say.
I was going to ask Dr. Ms. Brown, or Dr. Brown. I was going to ask her. So, why is it that these young folks are getting so much obesity? What is it that is leading up to these kids getting obesity? And then you can follow up with the question that Jocelyn asked you.
Okay. So we could be here all night and talk about the reasons. Basically, it's poor food choices and not enough exercise. And so I know that gets really, really complicated when you look at food prices. And unfortunately, the foods that are the cheapest are the ones that are not good for you. So I have a lot of clients, they can go to McDonald's and get 3 burgers for $3. And if I tell them it would be better if you ate an apple, it's $5. So, the math is difficult. Another thing that I see with my clients is parents are advocating their role as parents and letting the children decide what they're going to eat for dinner, when the parents should cook the food, put it on the table, and if they eat it, they eat it, and if they don't, they don't. But you don't jump in the car and take them down to whatever restaurant they want to go to. That's part of it. And so I remember, and I'm going to date myself, when I was a baby, I looked like Buddha. I mean, I really did. I had these big fat legs and fat hanging off of everywhere. And I asked my mother, why did you do that to me? And what she said was, when you were a baby, you were considered the picture of health. So there's still some people that think that a large child is healthy. But I got my first patient that was a type 2 diabetic that was 12 years old in 1991. So this has been happening for a while. So there are a lot of complicated, it's complicated. And if your income is limited, it is hard. It's not impossible, but it's hard.
So now, Dr. Johnson, we're going to let you expand on that, and then we're going to get back to how do we help to kind of remedy some of these the income issues as it relates to food, or food as it relates to income.
Right. Well, so when we talk about symptoms and what we usually are going to see as far as how a person might present with diabetes, usually by the time you're presenting with the diagnosis of diabetes, your sugars are really high. And so more often than not, people with type 1 diabetes will present. They'll be very thirsty, urinating a lot. They'll have lost weight. And some people will think, oh, I'm losing weight and I'm doing well. But it's really because their body is not using the sugar at all, and they're urinating it out. And so because they're urinating it out, then now they're thirsty. And so they are thirsty and they're drinking all the time. And it's after a while, they just tend to not feel well at all. Now, people with type 1, that can happen a lot more quickly. People with type 2 diabetes oftentimes have no symptoms for a long time. And by the time they're presenting with symptoms, they are presenting with things like heart attacks and strokes, because their body has been able to make some insulin and keep the sugar down some, but that damage is still being done to those vessels inside the body. So about 30% of people who have diabetes present in the emergency room and present with events that are complications of diabetes. And so that's why it becomes very important to make sure you're going to the doctor at least once a year, having your fasting blood sugar checked, making sure that you know what your numbers should be. I saw a patient today who was a brand new patient, and luckily I was able to pull his records from Quest, and as I reviewed his labs, his sugar had been high for at least the last 5 years. And so as I spoke to him, and it wasn't like 101, it was like 134 and they had done an A1C, and the A1C was 6.3, 6.2. And I was like, well, has anyone ever talked to you about your sugar? Now, I will be fair and say that most of the time the doctor has said something, but people are like, no, nobody told me anything about my sugar. And because of that, it's something that damage is being done on the body and the inside during that time, during even the pre-diabetic time. But I explained to him, if you have 2 fasting blood sugars where you went in that morning and his numbers were like he got them checked at like 5 o'clock in the morning, 6 o'clock in the morning. So the likelihood is that he really was fasting. And it was 134, 129, 143. And I explained that actually, if you have 2 numbers on 2 different occasions where it is above 126, that's diabetes. So even though your A1C has been saying pre-diabetes, this is telling me something else. Now, I wanted to gradually take him into it. So what my next step was, I went ahead and ordered a glucose tolerance test. So what a glucose tolerance test is we challenge your pancreas, because your pancreas is what produces insulin to control the sugar in your body. And so I wanted to be able to show him this is how your pancreas is responding. And this allows me an opportunity to kind of really break it down to him in at least 3 ways. Having those 2 fasting sugars that are already elevated, having the A1C give me a picture. And the A1C, I'm sorry, is a 3-month average blood sugar. It tells me what your sugars have been doing for the last 3 months. But that glucose tolerance test is a challenge. It says, hey, let's see how much this pancreas can respond to a good dose of sugar. So we bring it in and we give you some syrup to drink. And after that, we measure your sugar at 1 hour and then at 2 hours to see how well your body has handled your sugar. And by 2 hours, it should be back down less than 140. If it's not, you're either in the pre-diabetic range or the diabetic range. And when I am able to really paint the picture a lot of different ways, people are less able to argue about, I don't know what you're talking about. I ain't claiming that. I don't have no sugar. So
I hear that quite often,
yes,
that I'm not claiming diabetes. I say, well, you don't have to claim it, it'll claim you. You know,
right.
and Dr. Johnson has so astutely mentioned 3 of the ways to make the diagnosis of diabetes, which I talk to my patients about, in terms of the 2 fasting blood sugars greater than 125, you know, and also the 2-hour glucose tolerance test, and also the hemoglobin A1C. And then the last one just winds up being if you take a random blood sugar, whether it's 1 minute or 1,000 minutes after you ate, and you have a glucose of greater than 199, and have one of the following, at least one of the following symptoms: peeing too much, which is called polyuria, you know, drinking too much, which is called polydipsia, too much water, and then also eating too much, polyphagia. Okay, if you have either one of those and that combination and that elevated 199, greater than 199 fat blood sugar, then that's diabetes. So that's all 4 different ways. One last thing I just want people to remember is that when we start looking at the diabetes and you're having that the physician is talking about, well, your sugar's been a little high and it's this number or that number, you're not quite diabetic. A couple of things I read a few years back was that you really can have symptoms or warnings of diabetes long before you actually develop the symptoms of diabetes, and that is you can have an elevated fasting blood sugar. It hadn't quite met the definition yet, but your insulin levels start to rise because your body sense that you have so much sugar coming in. Your pancreas just say, okay, I can handle this, and it'll adjust to it. Mm-hmm. But at some point, your pancreas get to say, okay, I'm done, you're on your own, and then the sugar began to rise.
Right. Dr. Kane, and it's interesting, and so that is something that's very important. And I kind of 2 points I want to make with that. One, as clinicians, and one of the things that is sometimes a bit disappointing to me is that we don't do a good job talking to people about what their risks are before it sets in. So for instance, when I have someone and I know they have a family history of diabetes, then 100 isn't my number to start really talking to them. If I see it in the 90s, I'm like, hey, this is what's going on with you. This is your history. Here's the things that you need to do now. You need to try to be minimizing your carbohydrate intake, because this is your body is telling you that it can't process it as well. If I see signs like some acanthosis, which is this darkening of the neck. And so, Dr. Brown, you were saying your 12-year-old was that young type 2 diabetes. I had a 6-year-old who I diagnosed with type 2 diabetes, and her parents were both in that morbid obese range. And so as I'm talking to them about her diagnosis, and at that point, and this was a very long time ago, her A1C was 6.6 when we had first made, actually, I'm sorry, her A1C was 6.8. So it wasn't even like, not really sure. Right. But, she was 6. So you don't want to make a diagnosis of diabetes in a 6-year-old, but it was what it was. And that little kind of Buddha baby that you were talking about, that's exactly the presentation. But more than that, I asked the family, I said, is there any family history of diabetes? And they were like, no, but I'm looking at them, and they were not my patients at the time. But one was very fair skinned, but her neck was just black. And so I was like, well, how often do you go to the doctor? And of course, very respectfully, I explained to her, as I look at you, if I was your clinician, I would be worried about your blood sugar, because these are the things that you're presenting with. Not because you're overweight, but because there are very specific things that you're showing me that suggest that your body isn't processing sugar. So this dark neck or this darkness in the flexors in between the chest is something that's called acanthosis nigricans. And it's a sign of prediabetes or poor glucose tolerance. And so if you notice that in your children, if you notice that in yourself, those are reasons to go ahead and make sure you're seeing the doctor, make sure you are having your blood sugar checked. But more than anything, starting to make conscious decisions about what you put in your mouth and what you eat and how you care for yourself, because you don't have to walk down that road, at least not as fast as you're trying to. There are going to be risk factors. I have a few patients that are very thin, but mama, daddy, grandma, everybody has it. And so they have it. They exercise, they work out, but they haven't been able to fight it off. Most people, though, are able to. Food is medicine. Exercise is medicine. And so if you don't want to get to a point where you're actually having to take the medicine, then you want to be preventative and preemptive and do the things that are going to be best for your body ahead of time.
Let me just say this real quick, Ms. Turner, because I'm going to let Ms. Brown chime in on the medicinal foods. A hemoglobin A1C, I just want people to understand the difference between a hemoglobin A1C and your fasting blood sugar. The fasting blood sugar represents a picture in time. The instant that they drew your blood, it represents a picture in time of what your sugar was. The hemoglobin A1C is a video of the previous 3 months. Okay, so keep that in mind to know the difference between them.
And very often we'll get you on a day you did real good the night before. You done fasted like 25 hours before you came and had your blood work. So your fasting sugar is normal. But if your body mass index is over a certain level, I'm going to check an A1C.
Right.
Because and if anything in your history, if it said like 95, I'm going to check an A1C. And now insurance, I used to have a hard time because insurances didn't want to pay for it. But now they support this because they know the better job we can do in the beginning at diagnosing this before complications set in, then that's how we're going to help decrease your overall cost to them. So you want to make sure that you are not trying to beat the system, because I'm going to check all the different ways.
So Linda, I know several people who've been told, my doctor said I have pre-diabetes. What should they be eating or avoiding eating?
You know, even though we have standards for what pre-diabetes is, I almost hate the term. I almost hate the term because people think, well, I got a little bit of time, I can cheat, no, you can't. Because pre-diabetes means you've been warned, and if you do the right things, you can push it back. And so what people do for pre-diabetes is the same that you would do for diabetes. So people think that it's just about carbs. It's not just about carbs. It's about total calories. Because if you eat more calories than you need, your body is going to take some of it and convert it to blood sugar. It's going to take the rest of it, convert it to body fat. And when you gain body fat, your insulin resistance goes up. So it's all calories. But you do focus on the carbs because that has the most immediate effect. So it's all about the portion size. I mean, if you eat a piece of cake, a little teeny weeny piece, you shall not surely die. But folks don't stop at that. They'll eat one piece and say, well, I've already messed up. Let's just finish it off. And then they just keep eating and eating. So it's really about portion sizes, eating from all the food groups, not skipping meals, drinking a lot of water, a lot. There she has it. Drinking a lot of water and making good food choices. So I'll just say it. Fast food is not your friend. It is not your friend. The way the food is formulated, it is formulated for you to eat more and more. Now, you may say, I may be exaggerating. I have 2 degrees in food science. And what we learned in school was how to formulate foods for people to eat themselves into oblivion. It is a science. It's all about colors. It's all about crunch. It's all about sugar. To give an example, the country of Ireland rated Subway buns as cake. They rated them as cake because there was so much sugar in the bun. Why do they do that? Because you like the way it tastes. You like the way it tastes. So the thing is, my father was diagnosed with diabetes when I was 8 years old. And he came home with this diet sheet. Wasn't enough calories, 1,200. Daddy was 6 feet tall, so 1,200 calories wasn't enough, but that's what they gave him. And my mother goes, fine, we'll all eat it. So what she didn't know that she did for us is I'm not diabetic. She became diabetic 20 years after Daddy did, and I am 40 years older than Daddy was when he was diagnosed. So Mother actually saved us. She was trying to save herself, but she really saved us by having us learn to eat smaller portions so we didn't have that cake every Sunday afternoon with Sunday dinner. That was just a regular thing, have that pound cake. And there were only 5 of us, and the pound cake was gone by the end of the day. That was just too much. So she quit doing things like that. So what I like my patients to understand is being diabetic does not mean that life has ended as you know it. It means that you have to be careful. And I'll hear people say, well, I have to have this for the grandkids. No, you don't. If you're diabetic, your grandkids are at risk. So the best thing you can do for them is to teach them how to eat. So all the stuff that we, traditionally want to eat, or it's cultural, people say, well, this is my culture. We got to rethink that. We got to rethink that. So if you have a choice for breakfast between Honey Nut Cheerios and Cheerios, you're going to get the Cheerios, and you're going to measure them. So you just measure it. You measure it, and instead of having orange juice, you eat the orange. It's less than half the sugar. So it's simple changes that make a massive difference, just a massive difference. But we just got to rethink some things.
When you talk about portion control, I think that, restaurants used to really make plates so humongous. And I notice now that they've come back down in size. And I think it's important that people understand how to read food labels. And that's not something that people typically do.
Right.
Because I had a conversation with a coworker one day who said, oh, on this bag of chips, it's only 190 calories. I said, per serving, it's 2.5 servings in the bag.
Mm-hmm.
They didn't realize that, right? They thought, well, I'm getting less than 200 calories. And so really paying attention, I say, you just can't look at it. You got to know how many servings per bag. Look at that first. Then you start looking at the other stuff. And that's something that people don't do. And one thing that I learned from a registered dietitian, not sure if it was you, Linda, or from my health department experience, and I know I've mentioned it before on the show, is the importance of staying on the perimeter of the grocery store. Mm-hmm. Because the perimeter of the grocery store really has all the foods that we need, right?
Yeah. And I'm just, honestly, I'm very concerned right now, even more than I used to be, because of the prices of food. And so the foods that are not good are the least expensive foods. I have some clients that they live in hotels. So they live in rooming houses. So they don't have a way to really cook. And so they'll say, well, I'm going to eat the noodles. Well, when people say I'm going to eat the noodles, I know that means ramen noodles. So, okay, if that's what you have, let's talk about it. So I'll have them not use the flavor packet and not cook the whole packet of noodles. Cook 1/4 and then have an egg and some sort of vegetable. You can do that for under $5. You can do, it's not the best, but it's certainly better than just doing a bag of noodles and calling it a day. When one of my sons was in the National Guard, his guard mates asked him, are you rich? And he's like, what are you talking about? Am I rich? And they asked him, well, you've never had ramen noodles. Are you rich? And that really made me sad, but that's a reality for a lot of people.
I've never had them either, and I'm not rich. But I have to interject this, though, real quick, because it's something that we are promoting in the community, and that is to grow your own garden. Get you some seeds. You don't have to have a big land. Just get you some pots and grow your vegetables. At least that's one less thing that you have to buy when you go to the grocery store. I did have another question. Dr. Ford, why is it important for me to monitor my blood sugar levels on a regular basis?
So the reason why I try to make sure that my patients are monitoring their blood sugars regularly is because it's important for you to know what's going on with you when you're not there with me. So the idea is, now I like to see my patients who have diabetes every 3 months. Some doctors actually push that out even further. But if I'm only seeing you once every 3 months, a lot can happen in between that time. And your blood sugars fluctuate all day, every day, based on what you're eating. So when you check your sugar, one, you're checking to clarify how well controlled your sugars are. You also get a gauge into how the things you eat are affecting your sugar. So for instance, some people, they will think that they're eating healthy, but their body may not actually like some of those choices. So I have one patient who he's really excited because for whatever reason, he can eat a powdered donut and his sugar does nothing. It doesn't move. But if he eats a piece of watermelon, it goes up extremely high. Now, that is going to be different for different people. Now, most of the time, anybody who eats a donut is going to go up. But because I have him check, he's like, I check my sugar twice a day, and he has his little food label, because one of the things that is important in making a diagnosis of diabetes is equipping people to care for themselves the right way. We're doing this panel, we're doing this forum, and we're talking about, we have a registered dietitian here who is able to really teach people more globally. But each individual patient, when they get a diagnosis of diabetes, is one of the first things that should happen, is that they should be directed to a nutritionist, diabetes educator, so that they can get proper training on how to adjust their mindset to eat like someone who has diabetes, because that's the only way it's going to truly become a lifestyle. So as you get a diagnosis of diabetes, the other part of that lifestyle is managing it properly. It's a team effort, but you are ultimately the captain of the team. Your doctor is your co-captain. So as the captain of the team, you need to know the plays and everything that's going on, and we're here to support you. So you have to every day be accountable to yourself first and foremost. And knowing what your numbers are helps you do that. Knowing what the value of your foods that you're putting in your mouth helps you. So reading labels becomes important. But I haven't done a good job for you if I haven't directed you to a nutritionist or to a diabetes educator. So as clinicians, we've got to do better. Again, I have a lot of patients with diabetes. So today, had a patient, I've been taking care of her for about a year. And her numbers are good. We review, we always talk about it. And then today, my MA said, well, do you have your meter with you? And she was like, I don't have one of those. I have never had a meter. And I was like, how have you been my patient for a year? But she can't, in my mind, she had diabetes when I met her. And of course she has a meter. And of course, but it was one of those things. So she had never actually checked her blood sugar. So I had to teach her. I was like, okay, I was an hour behind. Everything was terrible today, but she learned how to check her blood sugar before she walked out that door. And that was important. She walked out with a new meter, and the meter I had in the office, her insurance was not one that I thought her insurance would cover, but I gave her that one and then sent the one that it would cover to her pharmacy, because I was like, not today. You will not be able to ever say again that you don't know how to check your sugar, that you don't know how to use a meter, because this is valuable. Another mistake that patients make is that they only check their sugar in the morning.
Right.
They only check their fasting sugar. So in the morning, that's the time you wake up, you haven't eaten all night, and it tells you how your day is starting. What I explain to them is that that's just the beginning. So I have patients check it at least twice a day, especially if they're just learning. And it's one of those things when I'm explaining to the best time to check it, it takes 2 hours for your body to process sugar the right way, or to process sugar in the way it's going to. 2 hours is a new baseline after you eat. And so because of that, you shouldn't check your sugar before. I try to train them not in the beginning to check their sugar before 2 hours, because I don't want them to get confused about, oh, my sugar is out of control or not. I had a patient, he called me, she was like, Doc, my sugar's 450. And I was like, okay, what happened? What'd you eat? And that's the first thing I asked him, what'd you eat? And he was like, oh, I had an icy. And I said, well, how long ago? It's like about 10 minutes ago. I was like, okay. So call me in 2 hours. He called in 2 hours. His sugar had gone down to 125, or it was actually good. But I was kind of glad he checked it during that time so he could see what an icy was doing to him, and that he would make a better choice the next time, but his body compensated for it. So we want to know what your sugar is doing kind of throughout the day, all day. And if you check it, do at least what we call a postprandial. Post means after, prandial means eat. So after you eat, at least 2 hours after you eat. That becomes confusing for some people because they're like trying to time 2 hours after they eat. So I say, look, before breakfast, before dinner. The reason I say before dinner is because it's usually been at least 2 hours since they've had something to eat right before they're eating dinner, and it makes it easier. If you only check your morning sugars, you have no idea what's happening to your body when you eat food. So I have people, their morning sugars will be excellent, always under 120. And for clarification, that's the goal, is in the morning, I want your fasting blood sugar to be less than 120. When you eat, I want it to be, because I'm a Nazi, and I want it to be less than 140 during the day, because I want you to be really aiming for tight control. Now, it'll say up to 180, but I want it lower. With that being said, when you eat, your sugar is going to go up no matter what. That's what it's designed to do, because you're releasing energy into your body. We want to know that those sugars are going down. So checking it to make sure that it is going in the right direction becomes that it's staying in a controlled area is extremely important. And if you stay in that range, then you're more likely to be at goal of less than 6.5 when you come to see me in 3 months. But if you only check it in the morning, you could be going up to 200 after you eat, and your A1C is really 9 or 10, and you are like, what's going on? And you have thought you were doing well, but you're not. So even if you're like, well, I can't check it 2 times a day, alternate when you check it. Sometimes check it in the morning before you eat. Sometimes check it before dinner, or 2 hours post.
How does exercise help with controlling your diabetes?
Dr. Kane, you're on mute.
We can't hear you. I mean, some people might like that, Dr. Kane, but we actually want to hear you.
So Dr. Johnson alluded to a couple of things when it comes to checking these sugars that I run into with some of these patients. And those patients who need to have their sugars checked more than once a day can also gain a whole lot of information if they haven't checked many times a day. And while I'm not promoting a brand of any particular type, I have those patients who are resistant to the stuff like Freestyle Libre or those continual glucose monitors type thing. And the point that I try to make to them is that, and you alluded to it, both of you guys alluded to it, right after you eat something, you can check it without necessarily sticking your finger. You can check it as many times a day as you want to, not using strips, doesn't cost you any extra money. But the most important thing is that it can give you some information as to how much that a pineapple upside down cake represented to your increase in sugar, or how much that icy that you mentioned represented to your increase in sugar. So it can give you a whole lot of information to help you judge some of the things you eat in the future. And we have a whole lot of people, I have a whole lot that kind of, I don't want to do that, Dr. Kane. I got to wear it all the time. And it's like, that's the purpose. So I'll know, and you will know as much as possible, you know, what your sugars are looking like from one moment to the next. One last thing, and I get off my little soapbox. One of the fastest growing group, or we've always recognized, fastest growing groups in terms of occupation winds up being truck drivers and policemen. Okay. Those guys work really long hours, really long. They work hard. The problem is they're sedentary with what they do. And so they are just, I mean, as a occupation that's very prone to develop diabetes, compared to others who can get up, walk around intermittently throughout the day. These guys drive so many hours at a time and really don't get the chance to get that exercise, even passively like many of us do. When I'm seeing patients, and even though I don't have time sometimes to exercise, I'm up and running so much, I don't get a chance to sit down. So that's kind of my exercise. I still have to do more, but it does have some level of activity to keep me from getting diabetes.
Well, what is exercise? Speaking of exercise, Dr. Kane or Dr. Foy, I remember one of my former coworkers. She was a registered dietitian. She told me, Jocelyn, when you're sitting down, get some weights and at least do some hand weights or whatever. What's the significance of weightlifting versus taking a walk? And I'm not to say one should replace the other, but what's the difference between how one or the other or both helps to manage your diabetes?
Let Dr. Johnson take that one out.
So exercise is extremely important to diabetes. Whenever you begin to exercise, your body actually releases insulin into your blood. It first releases sugar, and then following that, it releases insulin because it is trying to give you the energy that you need to do whatever task you're doing. But at the same time, it wants to make sure your sugars don't go too high, and it wants to get the insulin into the muscles to actually do the work, to do the activity that you're trying to do. And it doesn't have to be any running marathons type of exercise. So what studies have shown is that when it comes to diabetes, people who combine some aerobic exercise with resistance training. So not necessarily just weightlifting where it's heavy weights, but more resistance training that actually builds muscle and makes the muscles move and allows your body to use sugar better and more efficiently. Mm-hmm. Those are the types of exercises that are best when it comes to trying to control your sugar. But any exercise is going to be of value. What I tell people, and it's one of those things, the same way Dr. Brown doesn't like the pre-diabetes diagnosis. One of the things that has always, I don't think we do as good a job at is helping people understand that in that pre-diabetic range, there's opportunity. Mm-hmm. So the guidelines suggest that we should give people metformin during that time frame. However, that's based on our lack of faith in people doing what really works, which is appropriate lifestyle changes with diet and exercise. It is 20% better than giving metformin. And we have chosen to say, well, here, I'm going to write this pill. And if somebody wants to say that I'm bad because I don't write metformin for all of my patients who have prediabetes, that's fine. My goal is to teach people how to take care of themselves and to teach them how to do this without relying on something that actually isn't the best treatment. I'm going to equip you to treat yourself best. And the way to do that is with appropriate lifestyle changes, which can decrease your chances of progressing to diabetes by 54% as opposed to 34% with giving metformin.
And you don't have to run a marathon.
And you don't have to run a marathon. 30 minutes, yes. If you can get up to, because it doesn't even have to be here, go start running 30 minutes or walking 30 minutes. I want you to get to at least 30 minutes, 5 days a week, 30 to 45 minutes, 5 days a week. However, I want you to park further away so that you're getting more steps in. A good amount of steps a day is 8 to 10,000 for healthy people. 2,000 steps is a mile. You get 10,000 in, that's 5 miles. If you can walk that with the work that you're doing, and people are like, oh, I'm on my feet. Well, if you're going to count it, you need to actually count it, because a lot of times you're taking in a whole lot less steps than you realize. Park further away.
My arm, I'm getting a step on my
yes. Park further away at a grocery store. You don't have to park at the closest parking spot. So when you go to the mailbox. Stop pulling close to the mailbox.
Right.
Go actually walk down there. When you get home,
How'd you know I was driving to the mailbox?
get out of your car and actually keep your shoes in the car and walk down your street for 10 minutes in one direction and walk back. That's 20 minutes that you got, or 15 minutes. When you order takeout and then walk for 15 minutes because they'll say it's going to be ready in 20 or 30 minutes. Now, preferably you're eating at home, but if you're not, which a lot of us don't have the opportunity every night to get home and cook, make good choices when you go to the places, but also use that as an opportunity to walk down the street. You know, there are lots of ways to get exercise in. Instead of calling your friend who lives around the corner, walk around the corner to see your friend. Take the stairs. If you work on the 3rd floor at work, go up the stairs. You know, wear good deodorant, but hey, you'll be fine. Take the stairs. You know, there are lots of things. On your break, if you get an hour break, and it only takes you 10 minutes to eat, then take 30 of those minutes and walk around a parking lot. You don't have to have a gym out back, gym with your job. If you got a parking lot, a door to walk through, an area to walk around, that's really all you need. So all you need is some good shoes.
Well, I concur, you know, and you can do the resistance training when, you know, muscles have a lot more insulin receptors than fat cells do, muscle cells do. So they will help you use the insulin more efficiently and help cut down on the insulin resistance. And doing that resistance exercise, as Dr. Johnson said, is we're not asking you to be Annette Schwarzenegger or Arnold Schwarzenegger. We're just asking you to do some resistance exercise, increase a little muscle use, and that's, you know, that will help tremendously.
So, Linda, I have diabetes. I always have to ask you this question. What foods should I eat more of and what foods should I eat less of?
In general, because when you go see your registered dietitian, you're going to get a customized plan. But in general, you want to eat more vegetables. It's only 25 calories, high fiber. I'm assuming you're not adding the grease and all that other stuff. But you want to eat more vegetables. You want to eat lean meats because that'll help you not be hungry, because hunger is an issue. So lean meat, not necessarily eat more of it, but do eat lean meat. What you want to eat less of is your processed foods and your breads. And if you eat a starch, you want to eat a whole thing. And what I mean by that is a small baked potato versus mashed potatoes. There's this thing about compartmentalization, but the bottom line is you can eat an equivalent amount of mashed potatoes to a small potato. The mashed potatoes are going to raise your blood sugar faster and more. So if you eat a small baked potato with the skin on, your body is going to process that differently. So you want to stay away from things in a box. Now, that may sound oversimplistic, but it's really not. If it's in a box, it's been processed to be what we used to call idiot proof, so that you can just add water and it's done. What that means is your body processes those foods faster. So if you're eating more whole foods that you have to, they can be frozen, like frozen vegetables, that's fine. Baked potato, that's fine. Small sweet potato, even better. And then when it comes to the breads, you want to eat whole grains. So does it matter whether it's whole wheat bread or white bread? Yes, it does matter. It matters a lot because your body processes it differently. But ultimately, it's about the portion size, and it's about checking your blood sugar so that you know which foods you react to. Because, everybody want to talk to their friend, and their friend said, well, I can eat this. Well, maybe they can, but you may not be able to. And the only way to know is for you to check your blood sugar after you eat in 2 hours. and then see what your blood sugar is. I have people that'll their blood sugar will be 400 in the morning, and they'll say, "Well, I only had a salad the night before." So then my question is, what did you have for lunch? So if they had Popeyes or Red Lobster and ate those cheese biscuits and all of that stuff, that will raise your blood sugar, but it takes about 12 hours. So so you may eat a salad at night because you know you messed up at lunch. And so the next morning, your blood sugar's still high because you ate all of those calories at lunchtime and it took your body that long to process it. So the foods that I consider as free are your non-starchy vegetables. So you can eat all the celery you want, tomatoes, lettuce, and Dr. Kane is laughing. All of those non-starchy vegetables, eat those, fill up on those, drink a lot of water. And then one thing we are really bad at as Americans is if you're paying attention, your body will tell you when you're full. But we tend to eat so fast that we miss the signal. So once you start the meal with your vegetables and then eat reasonable portions of everything else, and then when you feel that you are full, actually stop eating. Just stop eating.
Now that's a good.
Even if there's food on the plate, stop eating.
Yeah, the problem with I used to have with that one is, growing up, how they taught you back in the old school, and that is you got to clean that plate. There are plenty of starving children over in Africa that if you don't eat all your food and blah blah, and it made me feel guilty for a long time. Even as an adult, I felt guilty about it. But the thing I wanted to get to because we wanted short on time, I go ahead and readily admit diet and exercise are the initial the treatment that we need. But Dr. Johnson, we need to just a brief, whatever you can, let's talk about the different medicinal treatments, the pharmacological treatments, in terms of what patients should be, maybe when their doctor writes something for them or let them know that we can do this and we can do that. Kind of give them the kind of a quick general overview of how to help gauge some of that.
So 30 years ago, this would have been a really quick conversation. We had one thing, insulin and metformin. That was it. Right. But now we have a plethora. We have so many medications that are excellent medicines to help get your sugar under control, along with lifestyle changes, diet and exercise. What's more important, though, is they're making medicines in a way that's not just about your sugar, because the reason why we want to treat diabetes is because of the complications it causes. And those complications are things like heart disease, number one, 5 times higher risk of having a heart attack or stroke when you have diabetes. Kidney failure, number one cause of chronic kidney disease and ending up on dialysis. So medicines now, there are many medicines available now that actually will help decrease your risk of kidney failure and kidney damage, heart failure, decrease your risk of heart disease. And they're very easy to take, very well tolerated. They mix well with other medications. So you'll see a lot of commercials about things, and people get scared when they see, and these are the potential side effects. So you have to remember when we talk about side effects and the potential risk of medications, that it's really about, we looked at millions of people, and if one of them had it and it was significant enough, then we're going to tell you about it on TV. However, the real risk and the real common potential side effects that people have is something that you want to talk to your doctor about and understand your risk. So when you see medicines like Ozempic and Trulicity and Bydureon, these are things where people have traditionally been very afraid of injections, but it's a once a week, very easy injection that can decrease your risk of heart disease and heart attacks. So they work really well with your sugar. They don't cause your blood sugars to drop low, but they're also now being promoted as weight loss medicines. So that is another thing that people in that pre-diabetic range if we're focusing in on weight loss, those types of medicines can help. Then you have a family of medicines, the SGLT2. Oh, and by the way, that once a week injection also is available in a pill. And so the pill version of that has the same potential benefits. So if you don't want to take a weekly shot, you still can get this in a pill, and it still
once a day pill.
Once a day pill, and it still has the same protections. Then you have a family that actually can decrease your risk of chronic kidney disease and also heart disease, also decrease your blood pressure. And this is a family called SGLT2s, where you see things like Invokana, and I don't know how to say that one for Invokana, Farxiga, Jardiance. Those are the commercials that you'll see. And those actually are very beneficial. But the biggest thing about these medicines is that they tend to be very well tolerated. Again, you always want to talk to your doctor directly about risk and benefits and looking at what your risks are. So for instance, a medicine like Invokana, in a person who might have had a previous amputation or who has what we call peripheral vascular disease or poor circulation, that isn't going to be my favorite medicine for you, because there were some things that showed that maybe people didn't do well if they were taking this medicine. However, if you don't have that risk, this is a great medicine to help protect your kidneys and to help decrease your risk of chronic kidney disease. So there's always going to be risk and benefits. Good conversations with your doctor is very important. First and foremost, metformin, who has gotten a bad rep that really doesn't deserve it. There's a reason why the medicine is free at Publix. There's a lot of miscommunications and misunderstandings. And although we do have some great other medicines, metformin has a role, and it's still the first and foremost recommended treatment orally for patients who have diabetes, and it's free. The Publix has been responsible and made it free. If you don't get it at Publix free, it's $4 at Walmart for 30 days, and it can also be very life-saving. And sometimes just a little bit of metformin is all you need to get those sugars down while you're working on the lifestyle changes. But if I never had to write a medicine, I would be all too happy. But that's going to depend on you. You have to be accountable and do your part in making sure that the plate that you fix, we talk about feeling guilty about leaving stuff on the plate, make a smaller plate.
I will add one thing to that, and that is, just like we always said, used to be said when you had high blood pressure, once on blood pressure medicine, always on blood pressure medicine. Those times have changed. Mm-hmm. So those people whom we may put on medicine initially for diabetes, particularly like if it's just one medicine like metformin or whatever, as you begin to change your lifestyle, you begin to change your behavior and change your diet, you may actually come off those medications. But it's on you. It's not on me. Okay. I will stop it if you don't need it. But if you need it, I'm going to keep writing for it. And you may or may not take it, but I'm going to keep writing for it. So it's all in the patient's hand. And I just need to be as Dr. Johnson said, the co-coach, the assistant coach, to kind of give you some plays for the offense. And then the defense and the offense is on you. But I give you a little offense.
And I'm going to just say this. I actually had a Heisman star player who is not trying to give herself enough credit, and that's Miss Jocelyn Turner, who, when I told her that she had diabetes, since you already put your business on the street, when I told her that she had diabetes, she went straight into, okay, what I need to do. And she has done phenomenal. She is my diabetes champion. Not only is she talking about it to make sure other people do the right thing, she has lost the weight. She is eating the right food. I might have got a couple texts about my sugar this, my blood pressure this a couple times in the middle of the night. No, I'm just teasing. But she has done phenomenal. So Jocelyn, you deserve to be our diabetes champion. And it's good that we're talking about this with you, because I know when it's personal and you can actually take it to the bank. So this isn't just talk, people. This is someone who's lived it and done it. And you can do it too.
She talked the talk and she did the walk.
Yeah, and I was actually going to end it and say that I started the show by saying when Dr. Foy told me that I have diabetes, I knew it was coming because my dad was on dialysis. He was Dr. Kane's patient, and I saw him. I saw my great-grandmother get her legs amputated. I knew my family history. I actually went to college to major in a health related field because I wanted to change the trajectory of my family's health history. And so this has become a passion for me, but I will say it publicly that with Dr. Foy and a whole bunch of people on my team, I moved my A1C from 6.5 to 5.8 without medications. I left Dr. Foy's office and text one of my former coworkers, who she does some work with, Linda. She's a registered dietitian and certified diabetes educator. I said, so what's normal? Why I didn't ask Dr. Foy that question, I don't know. What's a normal A1C, right? And so she told me, I'm like, oh my God, I'm close. So now my thing is to not stay where I am, but to go even lower. I say it to say I have friends who have family history of diabetes. Everybody in their family has diabetes. We can't change who our families are, but we can change the things that we can change. And that is what we eat, how we exercise, how we manage our stress, and just those general things that we have control over. And it's not, I'm never will tell anybody that it's easy, but it is possible. And so we like to end our show. Great conversation. Can talk on and on and on about diabetes. Great panelists with Dr. Foy and Linda. But we like to leave the show by asking our guests, what are your final thoughts to help someone else who might be struggling with diabetes and trying to figure out, or just in general, what are your final thoughts to them, Dr. Foy?
So my final thoughts is that when people think of diabetes, they get scared. And what I try to tell them, you don't have to be afraid of the complications because they're preventable. And it's up to you. You hold the keys to how well or how poorly you do. So try to make good choices. Try to decide that you are going to beat diabetes and diabetes isn't going to beat you.
Thank you. And Linda?
I like to just give people hope. You need some knowledge. You get the knowledge, you follow the plan, and you can do it.
Thank you. And Dr. Kane, we always like for you to also share your final thoughts about tonight's discussion.
Well, I can't do any better than what these two guests have said. I will only add to where I started out in terms of those added things that become a concern when I have a diabetic. I have to worry about their blood pressures and I worry about their cholesterol, because that triad, the three amigos, cause more issues in my community. As we say in Health Zone 1, zip codes 2, 4, 6, 8, 9, and 54. And because 18 abuts it so easily, and that's a long cholesterol row, I have to mention 18. Because we have such a high, the impact of those three diseases joined together can cause such morbidity, meaning sickness, and mortality, meaning death. I don't want to be remiss in making sure that people think about those and the diabetes, because sometimes, many times, it ain't just diabetes. Yeah, we see the other guys as well. So get to see a registered dietitian, talk to your physicians. If you don't have a physician talking to you about it, go see Dr. Trishella Johnson. She will. Okay. and so that we can have people who are giving back to the community, just like these two individuals are. They work hard. Okay. They come home and they're still working. We got them to work tonight. Okay. Despite they worked all day. So go see people like that, the people that want to talk to you and want to share with you what's the right thing to do, and have no remorse about doing so.
And I like what Dr. Foy said, and I just like to leave these final thoughts for people. Dr. Foy said, be the captain of your own health. Your physician would be your co-captain. The other people you want to have on the team is a good registered dietitian like Linda Brown. You all also want to have a good personal fitness trainer as well. And but the main thing that we want you to do is to go to the doctor on a regular basis, so you'll know when your numbers are out of control. Understand what your numbers mean. Don't just let someone tell you your blood pressure is 140/90 and let it go. Ask the question, what does that mean? When they tell you your A1C is 6.2, ask the question, what does that mean? You're planning your family reunion for this summer. Plan a time to do a family health history. Place diseases next to your family member's name, family members who are living or those who have gone on. But know your family history, know the legacy of your family's diseases. I knew my family's history with my great grandmother. Don't think that because you have not been diagnosed, because of your family history, if you continue unhealthy lifestyle choices, it will come to haunt you. Don't let that be your future.
It's a
Thank you,
crapshoot.
Thank you, Dr. Foy. Thank you, Linda. And thank you to our listeners for joining in tonight. Join us next Tuesday as we talk about another topic that's of importance to all of us, and that is dementia. So many of us have family members who have Alzheimer's or dementia. We're caring for them. Learn from our experts next week how to recognize the signs and what you can do, what resources are available for you in the community. And of course, if you don't have a good primary care doctor before I end tonight, look for Dr. Trishella Johnson Foy, Dr. Rogers Kane, and registered dietitian Linda Lockett Brown. Good evening and thank you.
Before you end, Miss Turner, Dr. Johnson, I don't know what your schedule look like next week, but look to see if you can join us again when we look at dementia.
Okay. All right. I got you.
Okay.
Good night, everybody. Take care.
Have a good night. Be blessed, everyone.
Thank you.
You too. Thank you.